I would like to invite our respected speaker, Professor Dr. Waseem Mujtaba. He is working as associate professor in Jinnah Hospital and Allama Iqbal Medical College here. He has a lot of experience in rheumatology and pain management, so he is appropriate person to discuss here the disease, and I assure you he will add value to your practice and to your professionalism. Dr. Waseem Mujtaba, please.
Thank you. I think without it I can speak well, no problem. So, Bismillah ar-Rahman ar-Rahim. Today our topic, as they have told me, that we want to listen about rheumatoid arthritis. And I thought that when I was a student, the most difficult portion was this rheumatological diseases, because these are systemic diseases and there are so many overlap syndromes, difficult to diagnose and then difficult to treat as well. So I have taken the field of rheumatology as my specialty after doing practice in medicine, and this is the most important topic. And I thought before speaking that what should I talk, and keeping in view that the most invited persons are the general family physicians, and this disease is a vast disease, systemic disease, lot of research, lot of new information, then I thought that I will just take an overview and then the new information which is there, just a sort of CME in a short period of time. Let's start when we are in clinics, all of us, we are able to find so many persons coming, young females, middle-aged females with pain, and with pain in the joints, but all the pain in the joints are not arthritis. These are arthralgias. For arthritis, the joint should be warm, red, hot joint. Then it is arthritis. Let's start with a case. A 36 years female. She complains of fatigue, and she has got right third metacarpophalangeal joint swollen, with left second proximal interphalangeal joint for last 5 months. But there is no morning stiffness and minimal response to NSAIDs. And the physical examination shows no other joint involvement and no rheumatoid arthritis nodules, and X-rays shows no erosions. Let's move to the labs. We found that hemoglobin is 12, the WBC count is 4,500, the platelet is 550. Oh, I think we have to take the charger. कोई है जो इसमें से निकाल लेंगे ना, बैग में से नहीं, बैग में से निकाल लीजिए. ये पिछले लास्ट आवर से सब में अब तक उसकी बैटरी जो अवेलेबल है.
ठीक है सर, पीछे ना हो उसका लॉक जो है.
So the platelet count, and this is the ESR, C-reactive protein is also a little bit high, and the rheumatoid factor is also positive, and doctor does a full clinical musculoskeletal examination and asks the other investigations. Now a little bit interactive in the start. What do you think about the platelet count? Is it normal?
More than now.
It is more than normal. So the platelet count, if it is more than normal, what it signifies? Okay.
Anemia. Because small, you see, it reflects anemia.
Okay. Anemia, the hemoglobin is all right. The platelet count is more.
But ESR is more 46. That is also giving to and C-reactive protein. Both these
So it is,
factors.
so thrombocytosis is there. It is simple. The thrombocytosis platelets count are the
450 तक normal.
हाँ जी 450 तक normal होते हैं. It is more than 450. So what it signifies if it is more? Look, this is also an inflammatory marker. When the platelet count is more, it means somewhere there is inflammation going on. And at the same time, for a 36 years old female, the ESR also raised. And then there is an other inflammatory marker. This is C-reactive protein. You people have got the idea. It is also an inflammatory marker. It is also a little bit more than normal. And rheumatoid factor, it is also positive. The dilution is telling. Okay, then meanwhile, look, the results are not back. The question is, so does she have this disease, rheumatoid arthritis, or not?
It is difficult to say at this
State.
Sure. So what we have got the idea that she has got inflammation, she have got arthritis of two small joints, and the ESR and these things are raised. So the suspicion, the question has raised, is it rheumatoid arthritis? How we can make the diagnosis when we know the disease well? So we have to have an idea about the disease first. So what rheumatoid arthritis is? The definition, it is a prototypic chronic systemic autoinflammatory disease with features of autoimmunity. This is first. So it is having the features of autoimmunity.
What
What's
does it mean, prototypic? Chronic
prototypic chronic systemic means when you take one field of rheumatological diseases, then one disease is the leading. And you like in pharmacology, the prototype drug and the other drugs, they have got different features a little bit than the prototype. Okay. So let's move to the other. This is the first that it has got autoimmunity. What else? The etiology still nobody knows. There are etiological factors but not clear. It has got pain, stiffness, swelling of joints, and it can result into ankylosis, fused joints, small joints. This is the third component, and it has extra-articular manifestation. So 4 features: autoimmunity. It primarily involves the synovial membranes and the joints, and it has got pain, stiffness, and these features, and with significant extra-articular manifestation. And these things, these definition points, they are going to tell you about the diagnosis and to make a diagnosis. Look, these are the typical appearance of the hands in when the small joints has been involved as an arthritis, inflammatory joints. This is you can well see. Look, here there is swelling, and look at the fingers as well. There is, and look at the wrist. There is definite swelling. So 1% population or 3 per 10,000 are having this problem. The female to male ratio is more. The female are 3 to 1 ratio, and then it is highest in the 3rd and 4th decade presentation. And there are 2 peak incidences, same, one in 3rd and 2nd, 4th decade. And it is a morbid disease. And description dates to the 17th century till now in the New World.
अच्छा सर, वो जो पहला केस था उसमें एक्स्ट्रा आर्टिकुलर जो कोई है थी उसमें finding?
We will discuss the case meanwhile while discussing the features. Look here you can see the joints with frequency: temporomandibular joint, cervical joints. The frequency is 40%, and even 10% you can larynx, you can involve this joint, and then the other 50%, shoulder 60%, sternoclavicular 30%, elbow 50%, hip joint 50%, wrist 80%. But metacarpophalangeal joints and proximal interphalangeal joints, 90%. So whenever a patient going to present with the small joints of the hand, then the suspicion of rheumatoid arthritis will be very high. But when he or she is going to present with the large joints, then the suspicion is a little bit less than the small joints. Then you are going to find that knee 80%, ankle almost 80%, and the metatarsophalangeal joints 90%. Again, we missed the foot. And there are so many things. In case of rheumatoid arthritis, sometimes the patient present with foot pain, first feet pain. So peripheral joints in a symmetric pattern, both sides.
Both sides.
The second, extra-articular involvement of the organs, skin, heart, lungs, eyes can be significant. Constitutional symptoms including fatigue, malaise, and morning stiffness, it will be there. So this is one more picture of a little bit closer of the hands with rheumatoid arthritis. Morning stiffness should be more than 1 hour. And it can be in the morning, but even with a long rest period, patient can develop stiffness. Not it is the morning only. The name is morning. It is basically after the rest. Or what you can say, the pain of inflammatory arthritis will be more after taking rest. And the pain of mechanical joint problem or degenerative joint problem will be more after activity. At the end of the day, one is at the end of the day, one is early in the morning.
Kitna minimum rest?
Whatever long, 6 hours or so. Our case, the patient did not have it. The morning stiffness was not there. So this is something which is against the rheumatoid arthritis. It includes.
सर इनिशियल स्टेज थी उसकी पेशेंट की जो पेशेंट आपने प्रेजेंट किया था
जी वो आगे चलते जाते हैं तो पेशेंट के बारे में बात आती जाएगी. Feet. So the most important thing is feet. With cock-up toes and bunions means this, the pads are more. Feet are involved 90%, as I have told you, and there are feet deformity can be there when the patient is presenting to you. What else? This is normal joint. You can see it. And this is the arthritic joint. What happens, I think, is if it is clear, you can see the bone erosions, the cartilage, the problem with the cartilage, and the inflammatory synovial membrane, you can see it. Then pannus formation, this is one of the pathological process in rheumatoid arthritis. And then the inflammatory, because of the inflammatory, this prostaglandins and all that, you can see that the collagenase, the connective tissue, a little bit the other soft tissue problem is there. This is, I think, very old when we were doing the histopathology and histology slides. So there is a difference in, synovitis and the normal synovial lining. This difference on the microscopic level. And model for the etiology of rheumatoid arthritis, how it acts. There is autoreactivity, genetics, and so many trigger factors. Then the immunity develops, and the immunity will go, the T cells are the most important. Their recruitment resulted into chronic progressive immune response, then synovial inflammation and joint damage. The cells, the key initiator of rheumatoid arthritis pathogenesis are the T cells. And here, the different things and different research which is coming on these levels, that interleukin-1, the TNF, they all are involved, cytokines are involved, prostaglandins are involved. These are the inflammatory markers. These are the things which now with biologics, they are targeting these things. Then what happens, same pathological process is going on, and it results ultimately into erosion of bone and cartilage. And this is a schematic diagram how the cartilage, the bone, and everything is because of the fibroblasts, the macrophages, the osteoclasts, and the blood vessels and pannus formation. This is all how the things happen here. And This erosions and juxta-articular osteopenia, these are the early features, not the early, the late, the mid features of damage which occurs to the joint. This is one new thing. Maybe most of you, some of you are knowing it and some of you are not knowing it, that early inflammatory signs, which are even not appreciable with clinical examination, we can find them with ultrasound. The ultrasound is which is very important now in soft tissue swelling, and we are frequently using it in arthritic cases. So that is the one new advance in deciding and diagnosing. Before, we have been diagnosing, doing bone scans and all other things to locate the inflammation. Then there are auto-inflammatory disease. Because it is an auto-inflammatory disease, there are markers, the auto-inflammatory antibody markers. ANA is positive in case of rheumatoid arthritis, only 20%. It is more commonly positive in connective tissue. Rheumatoid factor is also positive, but it can positive into other diseases as well. The new rheumatoid arthritis autoantibody is anticyclic citrullinated peptide, which is known briefly as anti-CCP. This is something which is new, not very new, but it is something which is important in the diagnosis of rheumatoid arthritis. Now it is included in the criteria as well. Ji?
This test is confirmatory?
This is more specific. We will talk a little bit after. So about rheumatoid factor, it is an autoantibody. First of all, it is an autoantibody. It is a human antibody against Fc portion of human IgG. Then usually IgM directed against IgG, but any combination has been noted. It binds the complement. This is important. Look, it is not diagnostic of rheumatoid arthritis. What I am seeing in my practice, a patient has presented with pain and somebody has asked for rheumatoid factor, and rheumatoid factor was positive, and the patient is receiving even DMARDs, and she or he was not having rheumatoid arthritis at all. So that is not at all a diagnostic test. It has got its value in diagnostic criteria, but not at all the only diagnostic test for rheumatoid arthritis. And it does not follow the disease activity as well. I mean, if it is more, the disease activity is more. If it is less, the disease activity, no. It has no role. The third, it can be seen any disease with polyclonal B cell activation. So the other disease, even in hepatitis B, you can find the rheumatoid arthritis positive. And so many other diseases, the rheumatoid factor is positive in the other diseases as well. So must keep in your mind that rheumatoid factor is not diagnostic for rheumatoid arthritis. Then this is the new antibody, anti-CCP. This is the newest autoantibody found in rheumatoid arthritis patient, highly specific for RA, but not sensitive. So I think you have got the idea of sensitivity and specificity. Some tests are more sensitive, less specific. Some are more specific and less sensitive. It is more specific. If it is positive in a patient, then it is rheumatoid arthritis. But if it is negative, it doesn't mean that the patient is not having rheumatoid arthritis. So it's positivity, almost sure rheumatoid arthritis. But if it is negative, even anti-CCP negative rheumatoid arthritis can occur. So the diagnostic criteria has got so many things in it. The second, it is a shared epitope, and rheumatoid arthritis disease with this coronary vascular disease, it has more joint destruction. And what is a citrullinated peptide? Again, that is something very, it is basically exchange of the charge arginine for the non-charged citrulline. There is some change at molecular level, which resulted into citrullinated.
CCP stands for?
This is anti-cyclic citrullinated peptide. I have mentioned before. नहीं इतना महंगा नहीं है, मतलब ये 1000 डेढ़ एक हाँ मतलब कुछ थाउजेंड्स में कुछ होगा डिपेंडिंग अपॉन द लैब। हाँ जी हाँ तकरीबन। So this is just the previous, it is since 1970s they are searching for the association with just HLA-DR4 and certain alleles, not very much sure, then also associated with the other, and they have defined, naturally in Pakistan we are not doing it. So these are some genetic predisposition to rheumatoid arthritis is there. Immune cascade, you can see this is what happens. You can see, as I have shown you earlier, the T cell is the most important. So the T cell, the stimulation of the T cell resulted into TNF alpha, also TNF, interleukin 1, interleukin 6. They are the inflammatory things which result into inflammation. Then again the same, because of the T cells, this anti-CCP and rheumatoid factors, they are also the antibodies. Okay, what to know about the etiology of rheumatoid arthritis? There is some genetic shared epitopes. There is autoreactive polyclonal B cells, autoantibodies, rheumatoid factor and anti-CCP, complement cascade activation, immune complex are formed, production of certain cell products that activate inflammation and destruction. These are cytokines. Interleukin 1 is involved, tumor necrosis factor is involved, interleukin 6 is involved. Okay. Now, it is a systemic autoimmune disease, autoinflammatory disease. How does the RA affect all these organ system? Look here. What it do by causing synovitis, by causing serositis, and then the nodules and vasculitis. These are the pathological processes, autoantibodies, that result into the extra-articular manifestation and the systemic manifestation. The different things which can occur with rheumatoid arthritis: Zika syndrome, dry eyes, and this is the secondary Sjogren's syndrome, defined as Zika with lymphatic infiltration of the lacrimal gland. The eye. Ji.
When your patient has got nodules, and rather than going to the rest of the methodology for diagnosis, you just have biopsy of the nodule. Can it be the diagnostic?
We will come to the diagnosis. There is a diagnostic criteria. That is also new. I am coming to that. So these are just the extra-articular manifestation. So thinning of the sclera and keratoconjunctivitis, it is also common with rheumatoid arthritis. Even the scleromalacia perforantiani, that complication also can occur. The lungs, most commonly affected, the extra-articular organ, and can develop bilateral pleural effusion, can be lung fibrosis, pulmonary vasculitis, and Kaplan syndrome. It has got, because of the rheumatoid nodules, this appear as cannonballs and small nodules on the X-ray chest. This is Kaplan syndrome. So it reported first in the coal miners with rheumatoid arthritis, RA nodules, and if only one nodule, then biopsy should be done. Don't always think that it is Kaplan syndrome. And RA patient should have nodules elsewhere. If it is Kaplan, then the nodules are not in the lungs only. You can find it. And also methotrexate can result into the lung problem, fibrosis, which can confuse with Kaplan syndrome. Look, summary of the rheumatoid lung.
composition क्या है?
जी?
Nodule की calcified होते हैं, क्या होता है? Connective tissue होती है?
In fact, this is a pathological process. जिस तरह मैंने आपको कहा था ना, हाँ, basically inflammatory ही बनते हैं ना.
इसका होता है central necrosis and calcium.
I will ये अभी आगे slide उसके लिए भी आ रही है. In fact, it is good that you are developing interest. I have not reached to that point and you are in advance thinking for that. It is good. So pleural effusion can occur and pleurisy can occur, and airway problem can occur with the rheumatoid parenchyma can be involved. and pulmonary vessels because vasculitis, lymphoid tissues can, and the treatment induce problem of lung fibrosis and immunosuppression result into reactivation of tuberculosis. Then rheumatoid arthritis can result into pericarditis as well. It is a rare presentation, and this is something, the link of rheumatoid factor and pericarditis is much. 93% the rheumatoid factor is positive when the patient presents with pericarditis. Then there are subcutaneous nodules as well, left-sided chest pain, friction rub, cardiomegaly, pericardial fluid it can show the low sugar, elevated LDH and low complement. Then the neurological complication can be carpal tunnel syndrome, which can occur with wrist synovitis. And then the most dangerous, and it can result into death, is C1, C2 subluxation. Subluxation means semi-dislocation. So that can result also, that is the most important. Whenever a patient of rheumatoid arthritis complaining of neck pain, then we have to be careful. Rheumatoid nodule for you. Now, it occurs over extensor tendons. Elbow is the most common. It is firm, occur with disease activity, can occur anywhere, have a characteristic pathology. These are all nodules. Pathology, there is central necrosis and histiocytes and fibrotic capsule. Ultrasound will show, if you do the ultrasound for rheumatoid nodule, hypoechoic and homogeneous mass with the anechoic center. Then even the rheumatoid arthritis can result into the vasculitis, can result into, the digital infarcts. These are the digital infarcts. These are warning sign of small vessel vasculitis in rheumatoid arthritis, and small vessel vasculitis can result in lung hemorrhage or GI bleeding, can result into. Even this gangrene can occur because of small vessel vasculitis. Okay, so this was an overview. So what new in rheumatoid arthritis? The pathophysiology, new genetic information, specific targeted immunotherapy, the use of the new biologics, and the discovery that rheumatoid arthritis has multiple subclasses based on the response to the targeted therapies. This is something which is new about rheumatoid arthritis. But we need to start therapy earlier at the molecular level. How can we do that? Let's move. The old American college criteria, the rheumatological diseases, they have got diagnosis, the clinical diagnosis. They have got clinical diagnosis. And for the clinical diagnosis, there are criteria. The previous criteria of American College of Rheumatology was morning stiffness. This was the first component, these seven features. Morning stiffness, arthritis of 3 or more joint areas observed by a physician, arthritis of hand and wrist joints, separate criteria, symmetric arthritis, separate. Rheumatoid nodule is one of the, as Dr. Jasra was telling, so it was in the diagnostic criteria before. Serum rheumatoid factor was also one of the diagnostic criteria. Radiographic changes, hand and wrist radiographs, erosions, or just juxta-articular osteopenia. So these were 7. Out of 7, 4 if there, then we diagnose as rheumatoid arthritis and start treatment. And the new, what is new? Morning stiffness has gone. It has gone. The rheumatoid factor has gone. That has gone. Now the rheumatoid nodule has gone. These two are remain. Arthritis of hands and wrist joints, serum rheumatoid factor. Now, the new ACR, American College of Rheumatology, and European Union criteria, European Organization criteria for rheumatoid arthritis are 4 domains. The first domain, joint involvement, maximum 5 points. Second, serology, anti-CCP and rheumatoid factor, maximum 3 points. The third domain, duration of synovitis, maximum 1 point. Fourth, acute phase reactants, maximum 1 point. Acute phase reactants, the inflammatory markers. you need 6 points for a definite rheumatoid arthritis diagnosis. So that is the most important, to learn all that how we are going to diagnose. So the first domain, the medium large joint, if only one medium or large joint is involved, that is monoarthritis of a large joint, 0 point. It cannot be if the other criteria is not there. If 2 to 10 medium to large joints are involved, then 1 point only. If 1 to 3 small joints involved, I mean of the hands, as I have told you, 2 points. Only the 3 joints are carrying, and keep the case there were only 2 small joints. So 1 to 3 small joints, 2 points. 4 to 10 small joints, 3 points. More than 10 small joints, 5 points. So rheumatoid arthritis, the small joints, symmetric, more than 10, 5 points. Note, patient receive the highest point level they fulfill within each domain. For example, a patient with 5 small joints involved and 4 large joints involved score 3 points. We will just consider the small joints only for the scoring system. No RA factor or anti-CCP, 0 point. 1 positive at low titer, less than 3 than normal, I mean third times normal, 2 points. 1 positive at high titer, more than 3 times normal, 3 points. So they are involved in the serology involved, the maximum 3 points. Then duration of synovitis, maximum 1 point. If it is less than 6 weeks, 0 point. If it is more than 6 weeks or longer, 1 point. The inflammation is there for more than 6 weeks or longer, then 1 point. Then come to the acute phase reactants. Neither CRP nor ESR is abnormal, 0 point. Abnormal CRP or abnormal ESR, 1 point. So that's how you make the 6 points, and this is a chart that the scoring system like this, and you will calculate the score, and if it is 6 points are there, then the patient is having rheumatoid arthritis. So that is this is the latest criteria which we are following nowadays to diagnose rheumatoid arthritis. Workup for rheumatoid arthritis includes what? Specific laboratory and physical, full examination, I mean the full family, the full history, family history, musculoskeletal examination, and all the serologies, CBCs, differential, ESR, C-reactive protein, ANA, rheumatoid factor, anti-CCP. On the spot imaging with musculoskeletal ultrasound for, newest modality, as I have told you. Joint tap, if required, if it is inflamed, you can. Synovial fluid analysis. And other X-ray hand, feet, MRI will show early erosions, and bone scan can be offered as well. Treatment before biologics. NSAIDs we used to give for stiffness, corticosteroids for inflammation and suppress the autoimmunity, disease DMARDs, the disease modifying anti-rheumatic drugs, drug of choice methotrexate weekly, but also cyclosporin, azathioprine, cyclophosphamide, they all can be used. Then these were these modalities, they are still working. I tell you, don't think that methotrexate is still, even starting before starting biologics, methotrexate, hydrochloroquine, these are even tried first, and the biologics even in combination, not only the biologics, the research, the things are telling the, so keep in your mind. Then there are biologics for targeted tumor necrosis alpha inhibitors. 5 have been approved by FDA. There are 5, and some of them are available in Pakistan as well, not all. Then we have got anti-SD20 B cells, rituximab. This is also available in Pakistan. And then we have got anti-costimulation blocking, CD80/86, CD28. These are also this is also a biologic. Then we have anti-interleukin 1 receptor, and it sometimes works, sometimes doesn't work. And we have got anti-IL-6 this is also available. So these biologics, they have changed so many things in the management of, but they are very expensive, and most of our population is unable to afford it. So where they work, just have an idea. This activated T cell, activated B cell, and activated macrophage. Look, the T cell, these they work here in the activated T cell. The rituximab activated B cell. Then here, this is the place where anti-TNF and anti-IL-1 and anti-IL-6, they work at this level. So it is saying the word, but this is something you can say it is political as well, and it is commercialized as well. Whenever there is some new drug, they are expensive. So word say like that now the era has changed. But this is, I mean, since I am in this field, when the first drug, look, when leflunomide has come, they said like the claimed like same that the era has changed. But when we worked it, when we used it, experienced, it was not having the same effects like this. So same, now they are claiming that it has been changed, but it doesn't mean that it has changed the word. They say no deformities. Yes, if we can start earlier, the deformities will not be there. Then there are no surgical process required, no splinting, there are no other assistance required. Vasculitis improve, nodules can be resolved, and lung less involved, and mortality a little bit decrease, and decrease incidence of non-Hodgkin's lymphoma. Yes, the research is telling like that, but the experience will tell further things when we'll go a little bit ahead. Now we can go to the summary to just revise all the things which we have discussed till now. It is an autoinflammatory disease with autoimmune features, resulting in symmetric joint destruction. Systemic, it is a systemic disease. It can affect eyes, lungs, heart, lymph glands. There are unknown antigen trigger, and genetic predisposition is a lot of research field. It is, we are doing autoantibodies, rheumatoid factor and new anticyclic citrullinated peptides define subclasses of rheumatoid arthritis. Pathogenic and prognostic significance because of these new autoantibodies have. It involves the innate immune system. Multiple effectors have release. We have just discussed it. The role of cytokines and other. Immune complexes and complement are active. Multiple theories have been proposed to explain the findings, and suppression of the autoreactivity improves rheumatoid arthritis. But targeted therapies have changed the course of rheumatoid arthritis. Information from targeted therapies suggests T cell or IL-1 suppression not help once the disease is apparent. So early diagnosis is important. And different response to the targeted therapies is showing that there is overlap between all these processes. And thank you for your kind attention. I tried to be brief and